Talking about the dural venous sinuses and the dural folds. A dural folds is basically the coverings of the brain. So the coverings of the brain, we call them the meninges. The outermost is dura, the middle layer is arachnoid, and then the innermost is the pia mater. Okay, so you can see there is a dura which is outermost. It's actually the one that is attached. It attaches to the bone, the skull. And then you have got the arachnoid matter, and then the pia mater that is adherent to the brain. So when you look at the pia mater, we say that this is adherent to the brain. It is thin, delicate membrane, and closely invests the surface of the brain. In other words, it closely covers the surface of the brain. It follows the contour of the brain, entering the grooves and fissures on its surface. So, in other words, if the brain makes a fissure, so these deep invaginations of the brain, we call them fissures, and then these ones which are not too deep, we call them grooves. So it will be able to follow all these. And because of this, can you see that the pia mater is going to be continuous with the brain all throughout, but on some points the pia mater will end up separating. Okay, like at this same point that you can see, it will end up, actually for this one it will not even separate. The pia mater doesn't separate, it is the dura that will end up separating. So the pia mater will remain adherent to the brain throughout. Arachnoid matter is avascular, it doesn't have any blood supply. From its inner surface, thin trabeculae extend down, crosses subarachnoid space, and become continuous with the pia mater. So you can see this layer that has been pointed at this here. It has gone thin trabeculae, thin things that are going out like to hold it with a layer that is down, which is the pia mater. Now, dura is the outermost layer. It has got the part that is attached to the bones. We call that as the outer layer because it is attached to the bone. It is also known as the periosteal layer. And then you have got the inner layer that is attached to the arachnoid matter. Okay, and we call it the meningeal layer. And the meningeal layer is the one that is going to continue with the dura mater of the spinal cord. The periosteal layer doesn't go all the way to the spinal cord, it's just in the skull, but the meningeal will continue to the spinal cord. So what happens is that these two layers, the outer periosteal and the inner meningeal, are normally adherent, but at some locations they end up splitting. For example, at this point you can see they've split, and because of that splitting, they end up forming what we call the dural folds. So dural folds basically come from dura mater when it ends up folding. Okay, you can see, for example, here is the dural fold. You have got the outer periosteal and the inner meningeal. These two layers are not separate, they are basically one, unless where they are dural folds such as these points, and then the spaces that they are going to leave, we are going to find the blood there, so we call those as the sinuses. Okay, so the dural folds are a lot, and we are saying the dural folds are created by dura. Just something for you to realize is this: we have said that the layers of the brain, you have got dura, arachnoid, and the pia mater. Not the layers of the brain, but the meninges. Below the dura, you have got what we call the subdural space. Okay? And then below the arachnoid, we have got the subarachnoid space. And then we don't have below the pia because the pia mater is firmly adherent to the brain. Okay? Now you also have the space above the dura, that's known as the epidural space. You need to understand that because you are going to be able to see some clinical application of all those. Epidural above the dura, subdural below the dura. If you say epiarachnoid, that will mean above the arachnoid, but we barely use that. Subarachnoid is below the arachnoid. Okay, so you have to know where cerebrospinal fluid flows. We'll talk about that. So the dural folds, you have got the first one, the falx cerebri. Actually, falx cerebri, it ends with R. So falx cerebri. This falx cerebri divides the brain into the left hemisphere and the right hemisphere. And then you also have the falx cerebelli. It is different from falx cerebri. Falx cerebelli is going to be dividing the cerebella is talking about the cerebellum, so it will be related to the cerebellum. You also have the tentorium cerebelli. Tentorium just means tent. It's like a tent, and this guy makes like a tent that will be able to separate the cerebellum from the big brain, which is the cerebrum. You also have the diaphragma celli, and we'll understand it later on. So the subarachnoid space is just a space below the arachnoid and above the pia mater. Okay, it has what we call the subarachnoid cisterns. So you have got the cisterna magna, also known as cerebellomedullary cistern, because it's going to be found between the cerebellum, and the medulla. Okay, cerebellum and the medulla. So cerebro medullary system, and this one lies between the inferior surface of the cerebellum, like down the cerebellum, and the back of the medulla. Look at this. This is the cerebellum that you can see here. When you look at the brain, the big part here is the cerebrum, and then you're going to have the brain stem where you have got on top the pons, and then you are going to have the midbrain, and then the medulla, and then you are going to have the spinal cord down. So just here where the medulla is down, and then this is the cerebellum, a bit down here, that's where I've got the cisterna magnum. It's an opening. At this cistern, that's where cerebrospinal fluid will flow out of the fourth ventricle. So in the cerebrum here, you have got the lateral ventricles, two lateral ventricles, and then as you go down, you are going to have the third ventricle, and then you are going to have the fourth ventricle. That is how cerebrospinal fluid moves. When it is made in the lateral ventricles, it will go to the third ventricle and then to the fourth ventricle. To move out of the fourth ventricle, it is going to go via cisterna magna. Okay. Now, so take note that cerebrospinal fluid is actually going to be found in the subarachnoid space. So from moving from the fourth ventricle, cerebrospinal fluid will now be able to enter the subarachnoid space, and then it will be able to flow into these dural venous sinuses, which are the blood vessels, and then it will be taken back to the blood vessels and as part of blood. But the details about the flow of cerebrospinal fluid, we are going to talk about it in neuroscience, in neuroanatomy, because you're supposed to understand that they can actually give you a table, just draw the flow. Cerebrospinal fluid, I remember in my test one, 10 marks or whatever that they can give you. So the spinal cord is also covered by the same meninges that covers the brain, and it has got the pia mater, the arachnoid mater, and the dura mater. The outer covering, the dura, is a thick, tough, fibrous membrane, and it envelopes the spinal cord loosely. Okay, and it is separated from the arachnoid matter by the subdural space. You have got a dura. Below the dura, you've got the subdural space. Okay, and then you're going to have the arachnoid matter and then the pia mater. And at the same time, the same dura is separated from bone, okay, from the bony wall and the vertebral column by the epidural space. One question that they can ask you, especially in clinical skills, is if you are doing a lumbar puncture, what are the layers that the needle is going to penetrate as you do a lumbar puncture? So for a lumbar puncture, you are going to start first the skin. After you pass through the skin, you are going to have what we call superficial fascia or subcutaneous tissue. That is another S. After the subcutaneous tissue, I've got what we call the supra spinous ligament, and then you are going to have the interspinous ligament. You are going to have the ligamentum flavum. After you penetrate those, now you are going to have the epidural space, and then you are going to penetrate the dura, and then you are going to enter into the you are going to enter the arachnoid, and then that's arachnoid matter, and then the subarachnoid space. You penetrate the pia mater, and then the needle would have reached. Okay, so those are the layers that you penetrate. But then you don't want to penetrate the pia mater because you want to find cerebrospinal fluid. Because once you penetrate pia mater, you are going beyond where cerebrospinal fluid is going to be found. Actually, the cerebrospinal fluid is going to be found with just inside the these meninges, and we talked about where they are found is in the subarachnoid space. Okay, that's the one that contains cerebrospinal fluid. The inner layer is delicate. Okay, it is a delicate layer, and when you look at the pia mater, it is attached through the arachnoid to the dura by the dent denticulate ligament. You have got these ligaments that will basically hold, you can see it here, they hold these layers. The spinal cord ends at the level L1 to L2. The dura mater, arachnoid matter, and the subarachnoid space will continue going downwards. That is why for a lumbar puncture, you want to go below L2. You want to use the space L3, L4, or yeah, you want to use L2, L3, or L3, L4. Those are the best spaces you want to use for a lumbar puncture. Because at that point, you are afraid of going beyond up because you can injure the spinal cord. The pia is going to extend downwards, the pia mater, which is the innermost layer, and that will form the phylum terminal, which is the continuation of the spinal cord at the bottom here. Okay, and the phylum terminal will pierce the arachnoid and dural sacs and pass through the sacrohiatus. The sacral bones have got these tumor openings that are the sacrohiatus to be attached to the back of the coccyx. So take note that this pia mater is going to be attached even to the all the way to the back of the coccyx, the phylum terminal. You also have got interconnecting channels within the central nervous system. Okay, in the spinal cord, you are going to have the central canal. The central canal is a space. Within the brain, you have got the ventricles. So the way you move when you look at these openings in the brain is you start from the lateral ventricles in the cerebrum, you go to the third ventricle, the fourth ventricle. If you are not moving out like the way we said here, like you pass through the cisterna magna, if you want to continue down, you are going to have what we call the central canal that is in the spinal cord. Okay, the central canal of the spinal cord continues with the fourth ventricle up, and on each side of the fourth ventricle you have got the lateral recess which extend to open into the lateral aperture. So you have on the sides of the lateral, the fourth ventricle, you have got openings. You have got the foramen of Luschka. So you have got two of these guys on the sides, and then you have got one opening that is on the middle. We call it the foramen of Magendie. So the foramen of Magendie is just one, while the foramen of Rushka, those are two. The fourth ventricle is continuous up with the cerebral aqueduct. It will continue with the cerebral aqueduct of Sylvius, and that is what connects it to the third ventricle. And then the third ventricle is going to continue with the lateral ventricles through what we call the interventricular foramen of Monro. So if you want to follow how cerebrospinal fluid moves, you start from the lateral ventricles, you are going to the third ventricles. But what do you use? You use the interventricular foramen of Monro. From the third ventricle, you are going to go to the fourth ventricle using the cerebral aqueduct of Sylvius. And then from the fourth ventricle, you are going to go into the central canal. Okay. On the sides of the fourth ventricle, you have got the foramen of Ruschka. Spinal fluid can also move there and then go into the arachnoid space. And then it can also go through the foramen of Magendie, which is just one. Okay. What is present in the so these things I've talked about, the lateral ventricles, the fourth, the third ventricle, we call them the ventricular system. Together with the cranial and spinal subarachnoid spaces, these guys contain cerebrospinal fluid, which is colorless and it's a clear fluid. It's clear. It has got little proteins and few cells. If you end up finding a lot of cells, you'll be thinking someone has got meningitis. Specifically, if you see a lot of white blood cells, you are thinking of bacterial meningitis because viral meningitis doesn't increase the bacterial cells. Bacteria actually eats up the glucose. So if someone has got bacterial meningitis, you are going to expect that glucose is going to be low. You understand the details in microbiology of these meningitis. So cerebrospinal fluid is about 150 mils and it acts as a cushion for the brain from sudden movement of the head. What produces cerebrospinal fluid is the choroid plexus. Choroid plexus is made up of ependymal cells that stick together, making more like an epithelium. And the choroid plexus is found in the lateral ventricle, the third and the fourth ventricle. So that's where is cerebrospinal fluid produced. It's not only in the lateral ventricles. All the ventricles are lined up by the choroid plexus, and so all of them can produce the cerebrospinal fluid. From lateral ventricle, you are going to flow via the interventricular foramen to the third ventricle, and then from the third via the cerebral aqueduct of Sylvius to the fourth ventricle. And and then the CSF will leave the ventricular system through three openings: the medial foramen of Magendie and two lateral foramen of Luschka to enter the subarachnoid space. Okay, you can see on the sides you are going to have the foramen of Magendie, in front you're going to have the foramen of Ruschka. And then once it enters the subarachnoid space, the cerebrospinal fluid is going to be reabsorbed into the venous system. Where is it reabsorbed? It is on the arachnoid villi and arachnoid granulations that project into the dural venous sinuses, mainly the superior sagittal sinus. So look at this. Cerebrospinal fluid went and flowed in all this ventricular system, and then it came out and entered the subarachnoid space. While in the subarachnoid space, okay, it will move from the subarachnoid space. This is the subarachnoid space somewhere here. Can you see these two things that are moving out? These two ones that you can see. This is what we call the arachnoid villi. Okay, and then you have got the arachnoid granulations. So it is via the arachnoid villi and the arachnoid granulations that the cerebrospinal fluid is going to move and then flow into this big space. This big space you can see here is known as the superior sagittal sinus. You have got a lot of dural venous sinuses. These are big veins, they collect blood. Okay, so it's no longer cerebrospinal fluid at this point, it has become blood again, and then it will go to the rest of the body. It will be pumped to the heart, and then it will be pumped again to the rest of the body, and then it continues like that. So a clinical note you need to take note is if there is an obstruction of the flow of cerebrospinal fluid, there's going to be an increase of this cerebrospinal fluid, and that causes the pressure, the intracranial pressure, to rise, and that will cause the swelling of the ventricles, that's known as hydrocephalus. Okay, you need to know the features of someone that has got hydrocephalus. You need to know the features. So what can cause hydrocephalus? You have got congenital problems like the Arnold Chiari malformation, and then you have got acquired like stenosis of the cerebral aqueduct by a tumor, or obstruction of the interventricular foramen secondary to tumors, hemorrhage, or infections such as meningitis. For example, here you can see a tumor there. We'll discuss the Arnold Chiari malformation in neuroscience. So if you can decompress, there can be decompression of the dilated ventricles by inserting a shunt, like you find a way to get the excess cerebrospinal fluid and take them somewhere. So you can connect a shunt to the connecting the ventricles to the jugular vein, to the abdomen, or to the peritoneum, so that the cerebrospinal fluid can flow from the ventricles there, maybe to the abdomen or the peritoneum. Okay, by that you are going to reduce on the pressure that is high. Is there any question so far? Okay. So continuing with the dural folds, we just supposed to discuss a bit of how cerebrospinal fluid flows. So at this point, you can answer any if they ask you to say talk about the flow of cerebrospinal fluid, you should be able to talk about it from the lateral ventricles to the third ventricle via the interventricular foramen of Monroe, to the fourth ventricles via the cerebral aqueduct of Sylvius. From the fourth ventricles, cerebrospinal fluid can decide to go down to the spinal cord via the central canal, or it can go to the sides via the foramen of Magendie, or to the anterior aspect via the foramen of Ruschka, to the arachnoid, subarachnoid space. From the subarachnoid space, it will go via the arachnoid granulations or arachnoid villi to the durovenous sinuses, and that means that it has gone to the blood and then to flow to the heart, and then circulation continues like that. So the dural folds, when dural matter folds, as we said earlier, it will make all these divisions that will be able to separate the brain into different parts. The first one is the falx cerebri. Falx cerebri. This is the falx cerebri here. Now you need to know that all these dural folds are going to be innervated by the branches of cranial nerve number 5. The sensory innervation will be the branches of cranial nerve number 5, the ophthalmic, the trigeminal, the ophthalmic, the maxillary, the mandibular. I'll just give you a simple assignment. Find out which which one is innervated by which branch. Okay, find out. That one came in last year's practical exam. We'll discuss it later. So the falx cerebri is this crescent shaped structure here. It separates the brain into the left hemisphere and the right hemisphere. Okay. So the apex, where is this guy attached? The apex is attached anteriorly. Anteriorly here you are going to have the frontal crest and the crista galli of the ethmoid bone. The frontal crest of the is of the frontal bone, and then the crista galli. And then as you go posteriorly, you are going to have it is going to attach to the superior surface of the tentorium cerebelli. You have got this tent down here. Okay, that's the tentorium cerebelli. So the upper surface of the tentorium cerebelli, that is where it attaches. And you can see that the falx cerebri, inside it, you are going to have the you are going to have venous sinuses. These are blood vessels. These are veins. Like you have got this my big vein on top. We call it the superior sagittal sinus. And then you have got this one which is down, which is the inferior sagittal sinus. So the upper margin has got the superior sagittal sinus, the inferior margin, the inferior sagittal sinus, and then on the base here, the base, you have got what we call the straight sinus. Okay, so take note of that. Very, very important here. The next one is the falx cerebelli, not cerebri, but cerebelli. And it is a small crescent shaped structure. Also, it projects vertically downwards in posterior cranial fossa. The posterior cranial fossa is back here. You can see the structure. This is the one here. Okay. So it is between the two cerebellar hemispheres. The cerebellum, just like the cerebrum, also has got hemispheres. So it will be able to separate the two hemispheres. And where does it attach? So the base of this one is attached superiorly to the lower surface of the tentorium cerebelli. So on top, you have got the falx cerebri, and then you have got the tentorium cerebelli. Down the tentorium cerebelli, you are going to have the falx cerebelli. The tentorium cerebelli is a tent that is separating the cerebrum. You can see here. This is the cerebellum. On top, you're going to have the cerebrum. But to separate the two hemispheres of the cerebrum, you have got the falx cerebri. Separate the two hemispheres of the cerebellum, you have got the falx cerebelli. And then the apex of the falx cerebelli is going to be inferior, and it attaches to the margins of the foramen magnum. Foramen magnum is the biggest opening that you have in the skull. So down here, you can see again, this is the one that has been pointed on by red. Okay. So how about the right and left surfaces? It is related to the cerebellar vermis. Now the cerebellum has got parts. The vermis, you are going to have the middle part, which you call the vermis, and then you are going to have the lateral aspects. Okay. So the posterior border of the falx cerebelli attaches to the internal occipital crest, and it encloses a occipital sinus. So you have got a sinus here, which you call the occipital sinus. The anterior border is free, it doesn't attach to anything. And then the occipital crest is just the inside of the occipital bone. Here, that's where it attaches. And it forms a horizontal roof. It's a horizontal roof between cerebral. So now this is we are done with the falx cerebri. This is now the tentorium cerebelli. It's horizontal. Okay. Tentorium cerebelli is horizontal. And this guy is forming a roof between the cerebral and cerebellar hemisphere, like separating the cerebrum and the cerebellum. Where does it attach? It will attach to the transverse sulcus, upper border of the petrous bone, the petrous part of the temporal bone there, and then posterior clinoid process, which is the posterior clinoid process that is part of this bone here. Okay, the middle part here. And then you also have the free border. The free border forms a U-shaped tentorial notch like this part. Can you see this part here? This is the free border, and it's between the anterior clinoid processes. Okay. So you also have now the dural venous sinuses. What are dural venous sinuses? These are channels which are just lying between the two dural layers. Just the channels. You can see these guys are there to allow for blood to be able to flow. Actually, the continuation of the flow of cerebrospinal fluid. So you have to know all of them. And when you look at these, you have got those that are paired. You have got paired durovenous sinuses and the unpaired one. You have got 6 paired, 4 single, and 2 multiple, like there are a lot. The 6 paired ones, you have got the sphenoparietal, you have got the cavernous sinus, the superior petroso, inferior petroso, the sigmoid, and the transverse. The single one, superior sagittal is single, inferior sagittal is single, the straight sinus is single, and the occipital is single. And then those which are multiple, have got the intercavernous sinus and the basilar plexus. So these are the ones that you can see here. You have got this one on top, that the superior sagittal sinus, and then the inferior is this one. The inferior is going to continue as the straight sinus. At this point where all the sinuses are connecting, we call it the conf, uh, con, confluence of sinuses. And then you have got the transverse. The transverse sinuses are on the sides. You have got on the left and the other one. And then you have got down, you have got the occipital sinus. You can see the transverse sinus, when it continues, it becomes the sigmoid sinus anteriorly there. And then you have got the petrosal sinus and connecting to the cavernous sinus that is more inside. Again, another view, this is it. The one labeled as C is the superior sagittal sinus. D is the inferior sagittal sinus, continuing with the straight sinus. And then E is the lateral sinus, that's the left lateral. A here is the falx cerebri, and then B here is the tentorium cerebelli. Okay, that's the one that you can say again. There are these guys that have not been labeled on the middle here. That is the cavernous sinus. That's where you have got other sinuses that are connecting, like the superior petrosal sinus. Okay, and then when you make a sigmoid appearance here, this will be the sigmoidal sinus. You can see they are not supposed to be hard for you to know. You can see again the sigmoid sinus is this one that is going down. Okay, like that. The sigmoidal sinus is the one that continues as the internal jugular vein. And you need to know how these guys will end up draining to the heart. Yes, please, is there a question? So to the superior petrosal sinus is you have got the cavernous sinus here, and then the superior petrosal sinus. The cavernous sinus is more inside on the middle. But the thing is that these sinuses connect. Okay, so understand it, even here you can see at this point that's where we have got the cavernous sinus. And you can see you have got a lot of these ones, the basilar sinus, there are a lot. You have got the sphenoparietal sinus in front there. And then you have got posterior, this is the lateral, not lateral, but yeah, is the transverse sinus. When it turns here, it is going to become the sigmoidal sinus. Okay. And then you have got the inferior petrosal sinus, the superior petrosal sinus, and then you have got the cavernous sinus at that point. Does that make sense? Okay. So the superior sagittal sinus, we've already described it. The dilated portion of this guy will end at the confluence of sinuses where the sinuses end up connecting. So what are the sinuses that drain into the superior sagittal sinus? You have got the superior cerebral veins, not only sinuses, but superior cerebral veins would drain into the superior sagittal sinus. Okay, that's where it drains, all these veins that you can see on top. Yes, please. So at this point, for head and neck, not really, but you have to know it for the neuroscience. You'll find it in test one, you'll find all the tests and the exam, it was there. Of importance that I want you to know is, okay, let's start with You need to know the characteristics of the durovenous sinuses. Number one is they have got endothelium, just like blood vessels, but they don't have any muscular coat and they don't have valves like the way veins are supposed to have valves. They drain the blood from brain and cranial cavity. They also absorb cerebrospinal fluid through the arachnoid granulation tissue and then receive valveless emissary veins. So they'll receive emissary veins to maintain an equilibrium of venous pressure. Emissary veins also don't have valves. So what are emissary veins really? These are valveless veins connecting durovenous sinuses and extra cranial veins. The veins that are outside the cranium will be able to connect to the durovenous sinuses which are inside the cranium via the emissary veins. So emissary veins provide a way through which infections can actually spread from the outside of the skull to the inside of the skull. Another importance is that they equalize venous pressure between the outside and inside of the skull. You also have what we call the diploic veins. These are thin walled and valveless channels present inside the diploid of skull, like the soft, should I say soft? Okay, the skull has got, it's not supposed to be this strong to bone like that, but you have got, the way cancerous bone is. So you have got these, the way it is looking like this. You can see the way the structure is looking. So that's why you'll be able to see these veins. So the diploic veins are absent at birth, but they are developed after 2 years after birth, and they'll communicate with the scalp. We'll talk about the scalp. You need to know about the scalp. Actually, each letter has got what it represents, SC, and then it will communicate with the meningeal veins and the dural sinuses. It's also a way through which infections can spread. Infections of the skull bone can spread to the dural sinuses because the diploic veins drain the skull bones. You can see the folds again here. Falx cerebelli separating the two cerebellar hemispheres. Falx cerebri separating the two cerebral hemispheres. And then you have got the straight sinus here. Straight sinus continues, remember, with the inferior sinus. And then you have got the tentorium cerebelli. The tentorium cerebelli is in the transverse fissure. This one. So the cavernous sinus, this is the cavernous sinus that you can see here. It's very important for you to understand the everything that you can see here. Thing is that this diagram can come for you to label. Okay, it can come. So what are the structures that you can? The cavernous sinus is this thing that you can see in blue. But you have got arteries that are passing through a vein. Imagine cavernous sinus is a vein, but you have got arteries passing through it. You actually also have nerves passing through it. Okay. So on top here, you have got what we call the optic chiasm, and it's important for you to understand how this is. Optic chiasm, what happens is that cranial nerve number 2, the one which enables us to see the optic nerve, when it carries the visual sensations from the left and to the right, it is going to cross, and it crosses on the optic chiasm to turn to the other side to give you the optic uh, tract that will go to the occipital lobe of the brain. At this same point, you also have the pituitary gland. So if you have got a tumor of the pituitary gland, you are going to compress on the optic chiasm. And so someone will end up with what we call hemianomy. They are going to have hemianopia. And this hemianopia is you just having a problem to see the visual fields. And specifically, it is bitemporal hemianopia. Like you can't see on the sides for both eyes, but you can see on the middle aspect. Again, you understand it much detail in neuroscience. You can see the artery that runs through the cavernous sinus is the internal carotid artery. Specifically, there's what we call the cavernous segment. And then you have got nerves. Starting from up, going downwards, you have got the lateral wall. On the lateral wall, you have got cranial nerve number 3, and then down it's cranial nerve number 4, and then you are going to have cranial nerve number 5. But for cranial nerve number 5, V1 and V2 are on the lateral wall. Okay, V3 is not there, it doesn't pass here. But cranial nerve number, so you have got cranial nerve number 3 up to number 6. So start number 3, number 4, number 5, you only have V1 and V2. Number, you don't have V3. Number 6 is not found in the lateral wall. Okay, it's found in the body. This is the one, the abducens there, near to the carotid. And then down here you can see the sphenoid bone with the sphenoidal air sinuses, and then you have got the nasopharynx down. Please, you should be able to label that. Because of those nerves that run through the cavernous sinus, if someone has got thrombosis of the cavernous sinus, like blood is clotting, okay, which is caused by the spread of infection from the dangerous areas of the face. Because remember, we said that the actually connections, the cavernous sinus actually communicates with the face. Let's say, for example, you've been punched on the face. Infection can spread from the face going to the cavernous sinus because there's a connection, and that is going to result into the thrombosis of the cavernous sinus, and that affects cranial nerve number 3, number 4, and number 6. Okay. So what will you be able to see? High fever, decreased visual acuity, like your vision is disturbed. Cranial nerve palsy, specifically cranial nerve number 6 is mostly commonly involved. Periorbital edema, swelling of the orbital. Okay, so those things can go wrong. So again, you can see this diagram. This is the pituitary gland there. Okay, you also have the diaphragmatic celli on top there in case they include it on the label. Sphenoidal hair sinuses. So the cavernous sinus, where does it receive blood from? It will receive blood from the cerebral veins, from the ophthalmic vein, specifically it's blood from the eye. That's why infection of the eye can spread to the cavernous sinus. It also receives blood from the emissary veins. Okay, emissary veins, these are veins that just connects the extra the area that is outside the brain or outside the cranium, extracranial communication. So, from, let's say, for example, from the pterygoid plexus or veins in the infratemporal fossa. So, the infratemporal fossa, the pterygoid plexus of veins will communicate to the cavernous sinus via the emissary veins, and it's a pathway of infection. Okay, so you can see the ophthalmic vein here. It is entering there and then communicating with the cavernous sinus. And cavernous sinus is paired. You have got one on the left, one on the right, and those guys communicate via the intercavernous sinus. You also have the pterygoid plexus of veins in the infratemporal fossa. You can see here to communicate via the emissary veins to the cavernous sinus. So relationships, you have got structures passing through, and we've talked about them. Internal carotid and abducens, and then you have got those that are passing in the lateral wall, starting from top going downwards, going up number 3, number 4, V1 and V2. Know their order. So what are the tributaries? Okay, what are the tributaries? So where does it get the blood? We've said from the orbit via the superior ophthalmic vein, okay, which is a branch of the inferior ophthalmic vein, or sometimes the vein itself, the ophthalmic vein itself. The central vein of the retina may also drain into the superior ophthalmic sometimes before going to the cavernous sinus, or the central vein of the retina can directly drain into the cavernous sinus. From the brain, you have got the middle cerebral vein, the inferior cerebral vein, actually superficial middle cerebral vein, inferior cerebral vein. So these guys are also drain into the cavernous sinus. From the meninges, you have got the sphenoparietal sinus. You can have questions, multiple choice questions, where they ask you the following are tributaries of the cavernous sinus, except. That's why you need to know all the following parts are going to end up draining to the cavernous sinus, except. Okay, so we've already talked about the communications. And then the next is the superior sagittal sinus. Of importance is, where is it found? It's found on the superior border of the falx cerebri, and it begins anteriorly at the foramen cecum. Foramen cecum will be just somewhere here. Okay. And the question is, where does it end? It ends on the confluence of sinuses. But when you look at the confluence of sinuses here, you have got the right transverse sinus. You also going to have the left transverse sinus coming on this confluence of sinuses, and then you have got the straight sinus and the superior sagittal sinus. But to be specific, the superior sagittal sinus drains in the right transverse sinus. Please take note of that. The right transverse. Okay, that's where it drains. So this one will receive from the cerebral veins, okay, from the diploic and emissary veins, and veins from the falx cerebri. The inferior sagittal sinus is on the inferior margin of the falx cerebri, and it joins the great cerebral vein of Galen to form the straight sinus. Take note of that. This is the inferior. They'll actually ask you what forms the straight sinus. It is the great cerebral vein of Galen and the inferior sagittal sinus. Those are the ones that will form the straight sinus. It's important for you to know that. It will receive few cerebral veins from the falx cerebri, and ends posteriorly at the anterior edge of the tentorial cerebelli. Okay, tentorial cerebelli just here. The straight sinus, we've already talked about what forms it. Okay, what forms the straight sinus? The great vein of Galen and the inferior sagittal sinus. And it will receive blood. The straight sinus will receive blood from the inferior sagittal sinus, the cerebral veins from the posterior part of cerebral hemisphere, the great cerebral vein of Galen, superior cerebellar vein, and then veins or from the falx cerebri. The confluence of sinuses, transverse and sigmoidal sinus, these guys. So the superior sagittal straight sinus and the occipital sinus will empty at the confluence of sinuses. Okay. The paired transverse sinus extends in horizontal direction from the confluence. So the transverse guys will extend in the horizontal, they go to the sides. Right transverse usually receives blood from the superior sagittal. The left will receive blood from the straight sinus. So even when we say the straight sinus drains on the confluence of sinuses, to be specific, it drains on the left transverse sinus. Important for you to understand that. Okay. And take note that as the transverse sinus leaves the surface of the occipital bone, they are going to become the sigmoidal sinus, and the sigmoidal sinus is the one that drains into the internal jugular vein. So the superior and inferior petrosal sinus, these guys, they will drain into the cavernous sinus. The superior petrosal begins at the posterior end of the cavernous sinus and drains into the transverse sinus and also receive cerebral and cerebellar veins. Okay, but we say the superior and inferior drain into the cavernous sinus, but they'll be receiving from a lot. Okay, from the transverse sinus. Actually, they're supposed to receive. They begin at the posterior end of the cavernous sinus and drain. They're supposed to be drain the transverse sinus or drain into the transverse sinus. They also receive the cerebral and cerebellar veins. But take note, if that's you about the drainage, superior and inferior, they will drain into the cavernous sinus. Inferior petrosal begins at the posterior end of the cavernous sinus and drain into the internal jugular vein. Okay, take note of that. And also receives blood from cerebellar veins of the enterocarotid. So where does the inferior petrosal drain? Internal jugular vein. But remember again, the continuation of the internal jugular vein is the sigmoidal. Where does the superior petrosal drain? It is the transverse sinus, depending with which side it is. The basilar sinus connects the inferior petrosal sinus to each other, okay, and to the vertebral plexus or veins. You can see the basilar sinus is very down there, connecting the inferior petrosal. So that is it on the dural venous sinuses, the dural folds, and the meninges.